Thank you very much.
Thank you very much for your presentation. I thank also the organizing committee for giving me the opportunity to deliver this lecture to this world meeting. My task will be to talk about liver metastases from breast cancer, and I will try to define indication and timing for liver resection, which not to be very easy. I will start with a small introduction on the disease. In 2012, the estimated age-adjusted annual incidence of breast cancer was 94 every 100,000 inhabitants, and the mortality is 23. The incidence is somehow growing because the introduction of the mammography screening and the aging of the general population. The estimated 5-year prevalence of breast cancer in 40 European countries was about 2 million. The prevalence is increasing because the incidence and because also the improvement of the treatments. However, even if the mortality for this disease is decreasing, breast cancer is still the leading cause of death for cancer-related disease in women. These deaths are due to metastases, to the metastatic spread. Roughly 5% of the women with breast cancer has already metastases at the time of diagnosis. In other women, metastases become apparent years or even after decades after the initial diagnosis. And the number of metastases also varies considerably. We have to notice that according to the American Society of Clinical Oncology guidelines, a search for metastases is not recommended after the treatment of the primary tumor in the breast, nor with the chemistry, nor with the radiological findings, if the patient is asymptomatic and there are no specific find at a clinical examination. The reason is that since the beginning of this disease, the metastases from other sites have been considered as a terminal event. Even if bone metastases, they carry a good prognosis with 40 months as a median survival and a good response to hormonal therapy and chemotherapy, metastases from other sites carry a very bad prognosis with almost 17 months of median survival. And that's led to consideration of these metastases as terminal events. 30% of patients after breast cancer will develop the metastases in some point during their disease, and 5 to 25% of the patient will have isolated breast cancer liver metastases, which could be amenable for somehow for direct surgery. There are some consideration about these metastases because metastases from breast cancer has an effective chemotherapy that was established a long time ago at the beginning of this disease. And even if the metastasis is resectable, chemotherapy is always the first line to be proposed. And maybe after breast cancer surgery, an abdominal surgery could be considered as excessive invasive. This is quite different from metastases from other organs, for example, from colon cancer, where chemotherapy has been established only recently. Surgery is usually the first-line treatment. When we take into consideration the number of these diseases, we can refer from a collective review from US, 8 international centers, 5 from US, over 24 years, and they were able to collect only 120 cases. In the same period, Mike D'Angelica from the Memorial Sloan Kettering Center calculated that 5.5 million cases of new cases should appear in the States. Approximately 10% of them would have liver metastases, thus taking the total number of 96,000 liver metastases. And this number are quite striking. There are no comments to do. Most of the liver metastases are not approached by the surgeon. Nevertheless, the surgery for non-colorectal, non-neuroendocrine liver metastasis is increasing over time. There are 2 different reports, one from Europe, from René Adam, and the second from US, and both reported the same figures. The number of liver resections increased over time. And the survival are quite good. And if you took the blue line, which is breast, they're not different from other survival after liver resection for other tumors of the liver. In 2006, René Adam set up a clinical score to prognosticate survival after liver resection for non-neuroendocrine, non-colorectal liver metastases. And having a breast primary tumor was considerable as a not negative parameters, giving no points at this score. 1/3 of this patient had breast cancer, as, just to remember, this score correctly categorized patient according to the survival after liver resection. The first paper of liver resection for breast cancer liver metastasis appeared in 1991. It is from Elias. And since that time, the question is, are those liver resection effective? And we still don't know. I will try to give you some ideas to have an answer. The first is to go through literature reviews. There are several reviews in the medical field. The problem of these reviews is that as you increase the number in the selection criteria of patients, you decrease the number of papers available. If you consider papers with more than 40 cases, you will have only 10 papers to examine. When you consider a paper with more than 5 patients reported, 33 papers. This is the first problem. There are a lot of papers with few cases. I will take into consideration two, the more recent. The one is again from René Adam. He reported that the principal series published until 2000, and it was able to find that survival is quite good after this resection, ranging from 21% to 58%. Mortality was absent in most of the series. Only one center reported 5% mortality after liver resection, and postoperative mortality is the usual following those kind of surgery. Unfortunately, with this review, he was not able to find any prognostic variables that could influence survival, and that was common to all the series published. So no prognostic factors came out from this review. The second review is from New Zealand. It took into consideration 43 papers. They start from a selection of 1,700 papers, and with the selection criteria, they were able to find 43 papers dealing with 1,600 patients. Some data from this patient, median time between breast surgery and diagnosis was 35 months. Indication for surgery was synchronous in 13% of the cases. Solitary metastasis is 55%, unilobar 64%. Most of the patients had chemotherapy before and after surgery. 30-day mortality, as already stated, was quite low, 0.7%, and 3 and 5 year survivals, 56% and 37%, which are quite acceptable, I believe. The main problem is recurrence. 62% had recurrence after surgery, and the liver is the main site of recurrence, being 61%. When we go through the studies, we can find the first problem. Well, in only 21 out of 43 studies stated systematic criteria to select patient. Only 6 studies has more than 50 patients. That's the problem of this review, because combining articles with a small number of patients, there is a significant heterogeneity in terms of criteria, diagnosis, and also treatment characteristics. When we go to the analysis of prognostic factors, we could see that only 22 studies out of 43 had an evaluation of those factors. And most of them were confounding. For example, age. Age was an irrelevant factor in 12 out of 15 studies. 2 studies out of 15 reported better survival in older patients, and 1 out of 15 report better survival for older patients, which is quite confusing. And for the other factors, there was no result which was relevant. So what we could take from this review is that the only positive factor is prolonged interval between breast cancer treatment and diagnosis of liver metastasis. But I have to mention one more study which was not included in these reviews. This is, again, a paper from the Paris group. They took into consideration in the period 1985-2012, 139 consecutive females, and for a total of 162 hepatectomies. That means that some of those patients had repeated hepatectomies. And they were able to find a good result since the time of hepatectomy, but good survival also from the time of diagnosis of liver metastasis, so including the time where the patient had chemotherapy. They were able, in these 139 patients, to find 8 predictors of survival. 4 were negative and 4 were positive. Negative predictors were having more than 1 metastasis, having tumors greater than 2 centimeters, being triple negative, and having microvascular invasion at the surgical specimen. Positive predictors of survival were instead a negative resection margin, having hormonal therapy before and after hepatectomy, having target therapy after hepatectomy, and the performance of repeated resection. As I already stated, this group in 2015 reported a series of repeated liver resection for breast cancer liver metastasis. And from this data, they were able to draw a normogram. In the normogram, you can put the values of the variables of your patient, and you will have a score. The total score can give you an idea of the 3- and 5-year survival of those patients, and this ran quite effectively because the calibration plot revealed a good correlation between the normogram and the real-life observation, even if this normogram has not been validated from data from other centers up to now. The consideration from this study was that hepatectomy are safe, they could be done, but accurate selection of patients for hepatectomy remains a crucial factor, the key factor of this operation. The second way to give an answer is to go through comparative studies. We have very few comparative studies in this setting. I was able to find out 4 of them in the world literature. The first came from a collective review from France, from Dr. Mariani. He was able to identify 100 patients treated surgically and 100 patients treated medically. Among them, they were able to find out patients with similar characteristics according to patient age, year of breast cancer diagnosis, so having a case control group. This is the design of the study. Patient with the breast cancer, less than 4 metastases, chemotherapy or hormone therapy, staging, and then 100 surgical patients on one side, 100 patients on the other side. They matched those patients and they were able to find 51 similar cohort of patients. And the result from this study, which is a key control, was that two groups of patients were similar. Indication for surgery. Indication for surgery was quite important. This is the only study which reported indication for surgery in patient with liver metastasis for breast cancer. The indication were resectable liver metastasis, less or equal to 4 nodules, stable disease or responding to chemotherapy or hormone therapy, and having a good performance status. Bone metastases were not an absolute contraindication for surgery if they were stable with therapy. And the result were that the surgically treated group had a quite significantly better survival in comparison with the non-surgical group. Positive factors were having no lymph node at the time of breast surgery, having few courses of chemotherapy before liver resection, having fewer metastases, and as stated, having surgery done. The conclusion of this paper is that liver resection for metastasis from breast cancer is associated with a genuine survival benefit. Second paper came from Italy, from the group of Polistino. In the period from 2004 and 2011, they were able to identify 26 patients. 12 patients were submitted to surgery because of the presence of cancer confined to one lobe, irrespective for the number of lesions. And they also had 14 patients treated with ablation. Those patients had the bilobar distribution of the metastasis in their liver. These 26 patients were compared with 38 patients with the same metastases that were comparable. The only criteria were no brain metastasis or no peritoneal carcinomatosis. The results were that the treated group of patients had a higher median survival, which was quite higher than the control group, 45 months versus 9 months. Liver resection performed better than ablation in those patients, and the actual survival were quite higher in the treated group respect of the control group. The third paper came from the Memorial Sloan Kettering Center. They were able to identify 167 patients with isolated metastases out of 2,000. Those patients were discussed in a multidisciplinary team, case by case. And after discussion, this is a retrospective study. After discussion, they were able to identify a surgical core, which included 69 patients, 41% of the population of the study, and a medical cohort of patients, 98 patients, 59% of the population. They also ran a propensity score to match those cases that were unselected before at the end of their study. And the result were that they were not able to find any statistically significant difference between the surgical treated group and the medical treated group. Even if they ran a propensity score with different intensity, low, intermediate, and high, there were no difference in the survival. The conclusion from the study is that surgery is safe. It does not compromise overall survival, but there are no associated overall survival's benefit in this study. The only survival for the patient is to be off of the therapy for somehow during the disease course. The fourth and the last paper came from a tertiary center in UK, namely the King's College Hospital. This is the report of the activity of a multidisciplinary team. They offer patient resection, strike after imaging or after chemotherapy if the patient had been treated, so 2 arms. Patients with hepatectomy, they are quite different from patients treated with RFI or chemotherapy. They have fewer metastases, they have more solitary metastases, but they have the largest liver metastases. The three groups, hepatectomy, RFA, and chemotherapy, they are quite different. Nevertheless, they could state that the survival in the surgical treated group was higher than in patient treated medically. Some consideration about 4 studies, because these 4 studies, they are not very usual. 3 of them all of them were retrospective. Only one, the first from Mariani, from the French group of Mariani, had indication criteria for the medical cohort, having less than 4 metastases without bone secondary metastases. Only one study included only surgery, the other included also RFA. Only 2 studies included the inclusion criteria for the surgical cohort, and only one study was a really case control study. For some reason, the 2 latter studies did not comment on the previous 2 studies. And then the only cost-utility analysis, a cost-utility analysis was performed in the US. They took into consideration resectable patients, and they found out what happened in the study group, resection plus systemic chemotherapy, or the control group only systemic therapy. I have to mention that indication for surgery, they took data from the literature, as in all the cost analysis studies published. The criteria for selecting surgical patients were the one published from Mariani. They had 2 scenarios. The first scenarios were patients submitted to liver resection and postoperative conventional chemotherapy, dividing in patient being ER positive or HER2 positive. And strategy B, only conventional systemic therapy. The second scenario was the same of the first one, liver resection and conventional systemic therapy, and compare where new drugs for this disease. Well, the unadjusted survival curves were all in favor of survival for patients treated with surgery and chemotherapy after. And when we go to the cost effectiveness, you can see that hepatic resection was cost effective both in the first case for, this is a liver resection plus conventional systemic therapy versus conventional therapy alone, was effective for the ER-positive group and a HER2-positive group. And the same if you consider the newer systemic therapy combination, liver resection was effective again in both scenarios. When we go to the cost effectiveness acceptability curve, the strategy chemotherapy, standard chemotherapy plus liver resection was most cost effectiveness in all the scenarios. The conclusion of this study is that liver resection plus conventional systemic therapy was more cost effective for patients with HER+ tumors. For patients with HER2+ tumors, the systemic was comparable because there is no big difference, but there was no cost effectiveness in adding new therapeutic agents in the chemotherapy group alone. So which are the take-home message at the end of the speech? Up to now, metastatic disease from breast cancer should be controlled by systemic therapy, and this is business of oncologists because we see very few patients with these characteristics. Liver resection can be an effective treatment for some liver metastases from breast cancer, even if we don't have defined solid prognostic factors, because from their review, it's impossible to achieve those factors. It's up to now, it's unlikely that there will be a comparative prospective single center trial could start in the future. For surgery, you should consider the presence of isolated liver metastases because their survival could be improved by surgery in respect to chemotherapy alone. Probably the number is up to 4. You should consider the interval between breast cancer treatment and diagnosis of metastases. The longest, the better. And the feasibility of an oncologically correct liver resection with free margins and adequate remnant liver. And the presence of bone metastases stable to chemotherapy should not be an absolute contraindication for surgery. No teams up to now has reported a downstaging with chemotherapy for those metastases. As an additional, resection could also decrease the need for cytotoxic chemotherapy, can reduce the tumor burden, thus providing probably an immunological benefit, and can gift the patient of some treatment-free holidays. But the selection of these patients should be performed in tertiary referral center that can offer the best short-term and long-term outcomes. And at the end, maybe we should take in consideration the conclusion of a task force of the European School of Oncology on the metastatic breast cancer. They stated that a small but very important subset of metastatic patients, those with a solitary metastatic lesion, can achieve complete remission and long survival. For this selected patient, more aggressive and multidisciplinary approach should be considered. I thank you for your attention.
We have 5 minutes for questions. I'd ask anyone that wants to ask a question to come up to a microphone, just announce your name and country, please, if you would.
Gianluca.
Hi.
Kito Fusai from London. Gianluca, I really enjoy your talk. A comment and a suggestion, perhaps. Unfortunately, unlike a colorectal cancer liver metastasis, with breast cancer liver metastasis, we are constrained by the nihilistic attitude that oncologists have. And we know very well that breast cancer patients are managed almost entirely by oncologists rather than surgeons. I'm not sure if there is any way to overcome this difficulty, but you showed very clearly the discrepancy between the catchment population of a few hundred thousand patients in the US and the number of patients ultimately resected. The second thing, which is perhaps a suggestion, you showed 4 studies which reflect that this is a feasible approach, potentially beneficial. And it might be the time now for a multi-center, even retrospective potentially, or even prospective, and perhaps endorsed by HBBA. Do you have any comment on that?
I fully agree with you. Well, the problem is that when you go to oncologists and you ask them, probably, sorry, Ned, I'm probably you have a different answer. But when you go to oncology, they said metastatic breast cancer is a systemic disease. You should not treat them with the resection, which is, I believe, an old concept from early stage of liver surgery, from early stage of breast cancer. Now things are changed, and I think that we should have some comparative studies on the efficacy of those liver resection for those patients, and maybe we could have some surprise. Well, I should only mention that I suspect that there are several disasters over the world of patients or women treated with liver resection with very quick recurrence in the liver or elsewhere, and they are not reported. And we should be aware of this. Probably prospective study should be better.
René?
Yes, René Adam from Paris. Thank you, Dr. Grazi, for this very extensive review. I mean, I have two comments. My first comment is that what we have to convince as a population is the medical oncologist. Why? Because, of course, they have the patients, and they didn't refer the patient to a surgeon, even when they may be an indication, for the simple reason of dogmatic or historical, I would say, comportment, behavior regarding this disease. So, because if we see all the data you have presented, all but one are in favor of combining chemotherapy and surgery. And so this is very clear. If we take a patient with isolated, very few metastases from breast cancer, if you ask a medical oncologist, how many of these patients are alive at 10 years, he say you, if it is honest, 0. We follow in our different surgical team, patient now alive without any disease at more than 10 years from the combination of chemotherapy and surgery. So if we want to go out of this and to see about perspective, the first point is a tumor board meeting, generalized, including the medical oncologist, and by discussing with them, we can convince them about the utility of combining chemotherapy and surgery. The second one is to do randomized study, and I contribute now in the EORTC, the European Association of Cancer in Europe, to try to do a randomized study comparing the conventional approach with a local treatment of breast isolated liver metastasis. And the third one, and this is very important for our association, is the creation of an international registry who will include all these cases of, I would say, liver metastasis from breast cancer in a way that, I don't know, in 5 years, we may have not only 20 patients or 100 patients in a single center, but possibly, I would say, 1,000 or 2,000 of patients treated internationally. And at that time, I think we will have prognostic factors.
I completely agree. Maybe you remember 30 years ago that even for colorectal metastasis, the approach from oncology was you should not operate them because it's already a systemic disease. And it took a while to make them understand that surgery was strongly effective in this patient. Maybe we should do the same work in the future for breast cancer liver metastasis.
Last question.
Thank you very much, Osama Hamid from Jordan. Question for you, like I've attempted, I had 3 cases of metastatic for breast cancer. What I found from this small number of cases is that, and I want you to comment on that, there's like something called satellite nodule. So there is like the main lesion, and there's almost in 3 of them, the pathologists were able to identify 3 or 5 small millimeters called satellite nodules. And the other thing that I learned is that in one of the cases, that what you see in the MRI or PET or CT scan is not really a real description of what's happening in reality with the intraoperative ultrasound, where you had one major lesion, there's like multiple other lesions elsewhere. So in this kind of scenario, you're going for a limited, simple, segmental liver resection. If this intraoperative finding you showed multiple, what it requires a major surgery, would you still do it, or would you just open and close and take biopsies? Thank you.
Well, I have to confess I have the same experience. Several times there is the main nodule and satellites nodule around. The answer to your question does not exist because the experience is very limited and nobody reported free margin or not free margin or distension margin. But I think you're right, and maybe for this surgery we should have wider margin in comparison to that we obtain after resection for colorectal metastasis. I fully agree with you.
And how about if you go in for a limited resection and you find that you will need more major resection? Would you still do it, or would you abort? Knowing that, again, we're dealing with systemic disease.
If the patient is resectable, I will resect the patient.
Okay.
Okay, I think we'll bring the session to a close there. I'd just like to thank Professor Grazi again for a most stimulating presentation. Thank you very much.
Thank you very much.